All right, I thought we'd get started. This is Eric Harrison at WFLHCA, and for showing cases that are relevant to CareAssure as well as to advanced cardiac imaging for the physicians who are in training, fellowship at Largo Medical Center, as well as cardiology at Bayonet Point, with residents who are interested in cardiology. We hope that you can get a mic next time because it's important to be able to communicate. But let's talk about an interesting case, or a couple of interesting cases we have today. And so we'll start out, the plaque is half and half. And there's a picture of half and half, and there's our Sherlock Holmes. And usually when we look at the plaque, we analyze composition, morphology, and function. And composition usually consists of understanding the necrotic core and its relationship to the plaque and how that promotes risk or danger. And so let's start with case 1, who is an 82-year-old Caucasian married male referred in 2013 by his longevity management physician, which is a new era of physicians that are involved in managing longevity for gerontology. And so this patient was sent over for cardiac risk assessment, which would be a big part of longevity. Cancer and cardiology are the two big areas in assessing patients' longevity. The patient denied chest pain, shortness of breath, hypertension, dyspnea on exertion, increased cholesterol, or cigarette smoking, just an occasional cigar. The EKG showed first-degree AV block, an interventricular conduction defect like a left anterior fascicular block, some PACs. With left anterior fascicular block, it's frequent that it looks like a negative axis, and there are Q waves in 2, 3, and F. And so questionable inferior wall MI, but usually not. And so to be able to read that vector in someone with left anterior fascicular block is very difficult. And but the computer frequently puts that up if there's no little R wave in 2, 3, or F. And then a sinus arrhythmia, which is common also, more common in younger people. But certainly he met the criteria. The only meds he's taking are a bunch of vitamins, no hormones, which people usually who are on longevity management are taking HCG and frequently testosterone, estrogen, other hormones. And so patient said he had a heart attack at age 61. I don't think this has been really validated in this gentleman. And it's just he's reporting something happened in the way of chest pain. His father had a heart attack at either 61 or 71. Patient doesn't recall. An echocardiogram was done on this gentleman, which is supposed to be Graham, not Grand, was normal. And his vital signs were normal also, and just corrected that. And we recommended a coronary CTA if you're ever going to talk about prognosis in someone this age. Certainly coronary CT is important. Some people would say body PET would be important for cancer risk. And so there are programs around the country. There's one in a Longevity Institute in San Diego that Craig Vender has, and basically looking for predicting cancer or predicting cardiac disease. And so let's flash forward 2 years. A gentleman woke up in the middle of the night, or actually at 1:30 a.m. with discomfort. Do I hear that? Okay. Woke up with some discomfort in his chest and was concerned about that. And also had a dull sort of chest tightness. Took an aspirin. Felt like he was having heartburn in the center of his chest. Took some Tums, felt better. No problems during the day. He swims, plays tennis. We had a couple episodes of nausea as well. EKG showed no change. Echo showed normal. At the same time, we were able to do a gallbladder ultrasound sliding the transducer down. He was NPO, and his gallbladder looked great. And CIMT showed some calcified non-obstructive plaque, and we ordered a coronary CTA, and he said at this time that he would have the test done. So we did it. So I'm going to show you that. And so here we are at our cardiac CT, which you recognize right away. This particular image is always very exciting to people to see this volume rendered image of the heart. And we like to look at the volume rendered image and to manipulate this particular image because it looks so much like a 3D model of the heart. The Jack Saunders model is just like this, and so the similarity is striking. Frank Netter used to do drawings that were similar to this, and so we're struck as we look through this by two things. One, sometimes the coronary arteries don't line up, and that's where these slices, 1, 2, 3, 4, usually 4 or 5 slices with the 64 slice CT, where the slices actually are put back together again in the heart to create an amalgam, and sometimes they don't quite line up, so that creates these artifacts that are readily recognizable along the fault line. And so then we see those and disregard them, but we look up here and you see that there is ostensibly a coronary artery lesion that looks like a severe stenosis in the LAD. So let's move towards that and see what we can find out about it. And so we're going to, this is obviously not a fault line that you can see, and there's an area of narrowing. So let's go up there and take a look at that in colorful mode, and let's make it bigger so we can see it better. And let's move up to it, and let's color code it for lumen, for wall, for the plaque. And so the blood moving through there will be green, and calcium, as you see, is designated yellow or white if it's really dense. And then over here on this side, the designation is blue or sort of purplish for scar, and red for necrotic core. The problem with the red is there's epicardial adipose tissue called EAT, E-A-T, that's surrounding the coronary arteries. The coronary arteries are embedded in that, and so that puts it on the outside, this red line. And so then we got to find red that's actually on the inside, and so we got to theorize where the wall is of the coronary to find where that's inside. So we can go down here to this plaque, and we can see on the inside we do have considerable red, which is necrotic core, and then we have narrowing of the lumen, and then we've been able to describe a convergent divergent double cone here, which represents the same as a rocket nozzle, which has real importance in terms of the morphology of this, in terms of causing increased velocity, decreased pressure, and stress on the walls of this vessel. And so we like to measure the necrotic core, which is the red, and these are our measurements. And so let's sort of move this up and down until we get it at the most significant plaque. And so you can see an obvious narrowing of the coronary artery, and then you can see obvious calcification on one side, and then we come back and there's calcification distally on the other side, and then the artery expands again. And then the measurement of the amount of necrotic core, which is designated color-coded red, is the highest number we've had of a necrotic core in a significant plaque. And so this is 51.1% necrotic core. And so there's very little blue. There's a lot of red. It is sort of reticulated, doesn't relate to be in one lipid lake, but it's reticulated, and you can see the diameter of this vessel and how much smaller it is, and we can measure that over here and give you some parameters that will be particularly useful. And so let's go across here, and here we are. And so the diameter is 68% narrowing of that vessel right there. We can move this along, and actually let's move this along, and we'll give you here being where we're going to be testing, and then we can move this, and we get various numbers in here: 49%, 62%, 52%, 53%, and so depending upon how we're measuring that, and then we're trying to get this up here. We don't want to include that branch, so it looks like in that particular place 74%, and let's go down. It's got that piece of calcium in it that's messing it up, so let's go down in here, 63%. So I think this is more accurate when we're down in here, and I think the highest I got in there was 68% when we did these measurements, and it's usually pretty reproducible. And so we were able to measure how far this was from the origin of the main left. And you can come back here, and you can straighten this whole thing out, and then you can measure from the origin of the main left. We get a ruler, we come up here at the origin, and then we come down here to the center of the plaque, and we get about 52.4 at the center of this particular plaque. And so somewhere in this 51, 52 range is where this significant stenosis are, right in the middle of the convergent, divergent double cone. And we can move this around a little bit and bring this down here to sub-10 this plaque. And there we are. And now you can also see how large this distal vessel is, and we can measure that from the plaque, because that tells you something about how much muscle is being subtended here. And if we were going to measure that, put this up here, and we shoot down from there and keep shooting down, and it's pretty long. We got 83.5 subtending, 83.5, and we've only gotten halfway down. And so we're going to go down further this vessel. There's some more down there, so I guess we're close to the end. So that's pretty much what we have. So it's a large amount of muscle that's being subtended by this, and it's right between the two diagonal vessels to locate where we are in terms of trying to figure out how much myocardium is exposed to this. And so these numbers and all this information steer us toward understanding how risky this plaque is, and what kind of problems we need to worry about here. And so that was the information we had, and we said this is a very high-risk plaque. It's going to thrombose, but we're going to put him on some medications and try to prevent that. And so that was our goal, and we found the origin of his chest pain. So let's go back to our slide deck. Hang on, please. So what we found was extensive coronary calcification, and then one plaque of high interest. Location, the LAD, the mid-LAD between the two diagonals, 52.7 millimeters from the origin. There was 83 millimeter long vessel. The composition was 51% necrotic core at the stenosis, and the whole plaque had 29% necrotic core. The morphology was characteristic of a convergent, divergent double cone, which is high-risk morphology that we found. We also had the patient come back and was fasting, and we gave him a fatty meal, something with a lot of cream in it, and did a gallbladder ultrasound and showed that there was no contractility of his gallbladder, so the ejection fraction of the gallbladder was abnormal, and so he does have a gallbladder problem with gallbladder dysfunction, and we did order a HIDA scan that would try to reproduce the same symptoms. I'm not sure if he had that. I think he did. We started him on aspirin. We started him on Ronexa, which is a late sodium channel blocker, 500 milligrams BID. We started him on Dexilant because of his symptoms that it may be related to GERD. He's been taking Tums and had some relief of some of the symptoms. Starting on Plavix and Lipitor. We did a pulse test, which is a test for markers of thrombosis, markers that preclude or sort of predict thrombosis in a vessel. And this is our image that we were showing you. 69% diameter is what we got here, measuring from there. And you can see the necrotic core is 51.1%, and so very, very high risk lesion in this gentleman who is in his 80s. We did do a HIDA-scan, even though our own little test was negative, the HIDA-scan was negative. Our own little test was actually positive, the HIDA-scan was negative, so we went with the HIDA-scan. The pulse test was 4.48 times normal, which is below our threshold of 5. We did a Lexiscan MRI to look and see if we saw any blood flow abnormalities on that, and we didn't. So we said we were pretty content with treating him medically and seeing how he did. His symptoms resolved, his nausea and vomiting went away, his chest pain went away. We continued the medications and followed up. In 6 months, he was doing quite well, and repeat the CT in a year, the echo, and the EKG was our plan. So he comes back in year 2, and he's doing great, and we're repeating the CT at that time to find out more about this lesion in the vessel. Here's our repeat CT, which we actually cut it off a little bit, and so we see a little bit of the ascending aorta, and we see less that we usually see of the inferior wall, because we're trying to decrease the radiation by doing just plaque-specific imaging. We probably could have just gotten this slice here and gotten all the information we need. We actually got 3 slices instead of 4 or 5 slices. So we're looking at the area of interest again, and it's right here. And you see it looks a little bit different now. It used to be that there was this calcium coming around the side, and then right here was a connection, so that's where the blood flowed through, and we don't see that connection anymore. So it looks like it's actually thrombosed, and what we're seeing is a piece of calcium that's sort of spanning both areas. So let's look inside this and see if that's what it looks like inside. We're going to make this bigger, and we're going to rotate it a little bit. And looking inside here, I don't see any contrast at all. So where we used to have that little bridge of contrast that was separating, I see right here that there's no contrast at all where it used to be. And so now if we apply the vessel tools for colorizing stuff, it will always make a little lumen, and it will make a very, very tiny little lumen. By the way, it's the program's written to differentiate high Hounsfield units from low Hounsfield units. It will always drill through and give you a little tiny hole. And so that little tiny hole doesn't mean that's open. And I think that it's closed from everything I can see here. And so here you can see the necrotic core is 42.6%, and we can move it along to here, and it's 37, 42.6, 44.8. So we still got a lot of necrotic core there, and we have an occluded vessel. And so if we take off this thing showing the lumen, there is no continuity of contrast spanning across here where it used to be. It's totally occluded. Right there you can see contrast ends. Contrast begins again, so that means that this is retrograde filling. And we can see lots of contrast, including a lot of calcification that was present before. There's no calcification here, and we see contrast. So it's going to be retrograde filling, and this is the same vessel we looked at before. And we can measure and show you that it's the same location as well. So if we start at the top starts right there. Let's get a ruler, start at the top, bring her straight down. We should be getting down here to, I went too far, right in here, 51, 52, and so we're getting 51.4 right there. So it's the exact same spot, so we can be sure of that. And so let's look at the myocardium and see if there's any damage to the heart muscle. If we've got an occluded vessel, we need to look for damage. So let's go back here to the gallery, come back over here, and select an image, and then we'll anonymize this. And this is our image. And we're looking at the myocardium to see if we see any fatty replacement. It would be subendocardial. And the sequence it goes through is the same as it goes through in the coronaries, where first you get necrotic core or fat, and then that's followed by fibrosis, and then that's followed by calcification. And so I don't see any definite, there's some black in there, but that doesn't look like it. I can't say, that's the only thing I see. I don't see any real linear subendocardial area of fat deposition or scar deposition either. So it doesn't look like it's infarcted. And then we did an echocardiogram that looks fine too. We can look at other areas over here. It would be anterior septal and apical would be the area we're looking at. So if this patient had been someone that was having hip surgery, we'd be very concerned about that lesion being risky for drops in pressure or for changes during hip surgery. So if it's a pre-op case, we would have some concern about it. And so now we've got just looking at this, we see very little in the way of subendocardial fat deposition. So it should be like right around there. So I don't see any definite infarct. It's got normal wall motion. EKG is showing no change. Still left anterior hemiblock, tertiary AV block. So we've experienced an occluded vessel. We haven't had damage, and he's asymptomatic now. And when he was having his symptoms, there was no evidence of a cardiac event. So let's go back to our slide deck again. And get back down. There we go. Total occluded LAD at the necrotic core stenosis site. And so there it is. It's very exciting because, again, we were able to predict that that was a high-risk plaque based on morphology, composition, and functionality. And so we did follow-up echo, normal wall motion, and even normal strain. And if there had been a cardiac event there, or if there was ischemia, the strain would not be normal. So we were going to show you a similar case of a gentleman that's very close to the same case, and see if we can draw some conclusions. So here's a 54-year-old married Caucasian male who woke up from sleep. Similar pattern. This gentleman woke up at 1:30. This gentleman woke up for sleep with jaw, chest, left arm, elbow pain. Instead of reacting and started sucking it up and taking Tums like the other gentleman did, and then taking an aspirin, this guy did go to the emergency room in Florida Hospital. He had some increased cholesterol. He had been on a statin. His liver enzymes were slightly elevated. He, before discharge, had an exercise SPECT scan. Said minimal supple reversible defect. They thought it was an artifact. He was seen in the emergency room there. A normal echo. Everything was normal. And so they didn't know why he had chest pain. He was sent home. And so nothing was found in this gentleman. And so he was okay. And actually he stopped his statin because of his increased liver enzymes and was on no medical treatment. Physical examination was normal. This gentleman, being part of a police department, basically there was a contract that he could go get a CT scan at a minimal expense, like $199, and so he went and got the CT scan, and here's what the picture looks like, and you can see some calcium, and you can barely make out some coronary vessels. And so this was done with a 16 slice scan. The contrast was injected, but the scan started before the contrast got to the left ventricle, and so this was a non-contrast study. This is the same thing as doing a calcium score, but doing a CT full dose with the injection of contrast, but the contrast bolus is behind the picture taking, and so it produces a study like this. And so this study, it was actually 250 in Largo, 16 slice scan, radiology read it, 25% LED, mid-LED, they call it 50%. I don't know how you read any of this stuff. No mention of coronary calcification. And so with an inadequate study that's non-diagnostic, you really can't see anything. His lipids were high. LDL is high. He's not on a statin drug because of his liver enzymes. And so but he has high lipids and cholesterol, LDL, and a low HDL, as expected. What to do next? And our standard is to do cardiac CT. And so the gentleman had a cardiac CT. It's kind of a waste of radiation. He had a full dose of radiation. They did the ejection fraction as well. And so we decided to do low dose radiation picture, see what his images look like. And so this is CT he had at Largo Medical Center for $250. Here's the CT he had for $199. And you can see the images are far superior because of 1, 64 slice scanner rather than 16, 2, somebody who knows what they're doing, 3, techs who know what they're doing, and then readers who know what they're doing are able to read this study. And so this was done, I guess, a few months after that one. And so we can actually show you some more of this, and we need to delete a name here. And so actually it's VinJer, so we don't have a name, and so it's okay. And so you can see here that the interruption in contrast that's taken place, and there is an area here where there may be some artifact, but there also is an area where there's no contrast at all, which is in here. And this is a totally occluded vessel. It's actually thrombosed, and this is an artifact from those slices coming together, and then normal vessel filling bicollaterals retrograde. And so this is a totally occluded vessel, 100% LED, rather than 50% LED that was cited by Largo Medical Center radiologists. And so we can show you that this totally occluded vessel also has a decreased iodine at the apex, which would be either anterior wall damage or ischemia, and then there's some inferior wall decreased iodine, and actually this LED does hook the apex and supply some of the inferior wall, so this could be artifact, which we usually see some basal artifact right in there, or this could be related to the hooking of the apex of the LED. And so it appears to be decreased contrast there. But you can't tell the difference between ischemia and infarct, but if you examine the myocardium in this patient, basically there wasn't any infarct on that exam. We can show you here, looking at the software, and this is the calcium score software we use. And we're looking to see if there's any artifact here, which is sometimes these black lines coming off of a dense subject will give you artifact. And then we can see the thickness of the myocardium, and if there was a scar tissue, the myocardium would be thin. You'd also see fatty replacement, and I don't see any fatty replacement. And so, so this is not an infarct. There's adequate collateralization. And we can actually show you the image if you hold on for a minute. We'll get the CT image up. So that would be Vince Gerasitano. We should have to query G-E-R-I-C, and it should come up. And then we have the one from Largo, and we have our own. There's two of them there. One's Largo and one's us.
This is Largo, I think.
And so let's get the Largo up, which is the first one.
It can only load it in raw software.
No, it should load into the regular. If you open it and then look for the 75%. Yeah, that'll load. And it'll come up. So these are the images from Largo, and it's not Largo Medical Center HCA, it's actually Largo Radiology, Rose Radiology. And so we'll show you these images because they're in such poor quality that you need to know non-diagnostic images when you see them, because it's important to recognize that the image is non-diagnostic, and so then the information conveyed is of no value. And so what we see here is that we don't see a bolus of contrast. So let's go find the bolus. And so here's some contrast that still seems to be in the subclavian, coming across the superior vena cava, and then superior in the vena cava. And it may be that when the contrast got here, that it triggered turning on the image CT scanner for imaging, because you usually put a marker in the ascending aorta somewhere, and this contrast is putting off these rays of starburst that would trigger that. And so it probably, the trigger is up here, and this is triggering it, and it starts shooting before the bolus gets where it's supposed to be, which is in the ascending aorta, because the bolus is in the superior vena cava, is triggering the sensor that's been put in the ascending aorta. So that may be why these images don't have any contrast in them. So this is actually a calcium score image that's been produced here, and you can see the calcium very well. And then you see, you know, the blood that's in the vessels, but you don't see contrast in the vessels. And so this is the left anterior descending, and we can color code this, but it's not going to color code very well. And so it's going to call that contrast even though it's not. And so there's that study, which was of no value and has to be labeled non-diagnostic study. So let's go to the other study. Hold on for a minute. So these are our images, which you can see what it looks like when you get contrast in it. Let's go back to this image over here, and we'll show you where the contrast bolus is. And here's the contrast bolus. We don't put our marker up here, so if there's rays coming off of here, you see starburst rays coming off of here, it's not going to contaminate our marker, because we're going to have our marker in the descending aorta somewhere way down here, and so it's not going to be triggered. And so it's going to be triggered when the contrast is coming down the descending aorta, which means it's still in the left ventricle, still in the left atrium, and still in the coronaries, which is even more important. So you can see this ventricle, and there's no evidence of any damage to that ventricle. You can see that quite well. Let's go back here. And we can triangulate it and look in several views, and there's no damage to the ventricle at the apex. There's no fatty replacement, there's no abnormal thinning, so it hasn't been damaged. It's hard to tell where the collaterals are. Let's look at the main vessel itself. So here's the left anterior descending. There's an artifact in the left anterior descending. But as we come down here, you see the contrast, and you see it becomes very dark, and it gets down to 34. So that's not there's no contrast in there. And then we come back up to 496. We come over here. We're down in 45. We get pretty low in here. So this is where it's totally occluded. 42. And there's no other coronary disease evident here, other than a little bit of coronary calcification, and that's it. Let's go back to our slides. And so we got two cases that we presented to show some commonality. And so we're dealing with what's called little data. You know, what can we learn from little data to apply to big data so as to ask the right questions? And so certainly in triaging these patients, neither one of them early when they had their symptoms would be someone that we want to do any kind of surgery on because of their symptoms. Even though they didn't have a cardiac event, they must have had high-risk plaque, and then eventually went on and totally occluded. So, but the commonality here is very interesting. The abrupt onset of symptoms. First onset of symptoms, not exertion related, just came on. Both of them came on at night, woke them up. One went to the hospital, one stayed home. No cardiac events by EKG, troponin, echo. Symptoms disappeared. One was treated medically, one wasn't. Totally occluded mid-LAD was found later. Normal echo and EKG. Obvious collateral circulation has been theoretically established. No need for intervention in either one of them because here we're a year out, actually 2 years out on one of them now. Failure to recognize occlusion in mid-LAD until imaged is certainly what we dealt with, even though it was tested with EKG, echo, and troponin. It didn't show anything. Precursor vulnerable plaque characteristics was on one patient. The other patient, we didn't have that opportunity. And then the difference. The first case was discovered symptomatically before occlusion of the LAD, and LAD occlusion was predicted, and treatment was started. Aspirin, Plavix, Lipitor. The second case was discovered a year after one-time symptoms occurred, ER visit, ruled out and sent home, and after mid-LAD occlusion again, had been found late this time. Discovery was after the fact in an untreated state. So how can this information help us in the future? This is anecdotal information. It's two cases. Both of them did well. And so let's turn to what we're doing with IBM Watson and what kind of questions we need to ask. And so we're part of this IBM Watson project for IBM Watson Health Medical Imaging Collaborative. These are the members of this collaborative group. Our company is Private Cores in Tampa, and our part in this imaging collective is coronary plaque imaging module with cognitive computing. There are other people here that are involved in eyes. There are other people here that are involved in cancer, and so this is our particular area of interest, and we're involved in this particular group, which actually is like 3 of us that are involved in this. I'm primarily coronary plaque imaging. We're in phase 1 of this project. Well, how's Watson going to make things different? And how's it going to change your practice? And so it's going to make the evidence hierarchy drastically change because of the application of big data. And so where am I today? I'm background information, expert opinion. Expert opinion is the lowest valued. The lowest valued is expert opinion. Why is that? Well, most people who are, quote, experts are university professors who migrated from hospital to hospital 5 years, 4 years at one institution as they advance the medical hierarchy, and so they've never seen a patient longer than 4 or 5 years in follow-up. And so they need the guidelines as much as the medical students and interns and residents need the guidelines. And so expert opinion is of low value. What about case reports and case-controlled studies? Case reports are next to lowest value because it's not a randomized controlled study. It's not validated in terms of statistical validation. And then there's cohort studies where you match a group up to the group that you have. And so basically, they're not randomized, they're just a group that matches. This is all called unfiltered information. And then there's what happens to be, you thought, at the top of the pyramid, randomized controlled trials, which aren't at the top of the pyramid anymore. They're actually somewhere just above the middle. And so randomized controlled trials have their problems as well. And so we've had controlled trials where there have been real question as to the number of patients involved because we predicted a cardiac event rate of 3% per year, of 9% per year, and it turned out to be 3% per year. So we didn't have enough patients, and we didn't follow them long enough. So randomized controlled trials need to be filtered in order to understand their value. And so then we get into critically appraised individual articles, synopses, critically appraised topics, and then systematic reviews like meta-analysis of a whole bunch of randomized controlled studies all put together and analyzed as a group, throwing out those that don't seem to be to fit or don't match or have fatal flaws or randomization defects or something in terms of a logic failure in putting the trial together, or maybe a problem in completing the trial. And then at the top is going to be IBM Watson, because IBM Watson is capable of putting all of this together, is capable of reviewing the literature on a daily basis as it occurs, 50, 70 articles a day, 1,000 articles a day, 2,000 articles a day, 10,000 articles a day. Okay? Watson can review in real language and understand the syntax and pull out the words and basically come up with what the current knowledge is and what the core of information is. Watson can also review charts, and let's talk about that. So you take my small database that I've gotten from personal plaque analysis from our Sherlock program, and you bring that data up as a feedback loop here, and we bring in HCA, hospital, multiple information from their data that's coming to a core laboratory, and that compromises then big data. Say you have West Florida, 16 hospitals. Say you have 20 divisions. Say you have 169 hospitals. That's a lot of data. And say you have 62 CTs a day. That becomes 20,000 CTs a day in the whole network. It becomes a lot of CT scans, a lot of data. And we have EMR, so we've got information on each individual patient. That can be advised, that can be certainly curated on its way in, and then it can be filtered by Watson to get the information and classify it, put it in pigeonholes, and understand it. And then that information then can be pre-processed and pre-digested and come back to the EMR and be inserted in the EMR for a doctor to check over their images or their thumbprints, check over the diagnoses, and then confirm it with a signature and charge for it. And then that goes in the medical record as an actionable data to be used. And then as that action takes place, that information can flow back as a feedback loop to a supercomputer that then can correlate what the data showed that went in and then what the outcome was, and then follow up outcomes based on what the information is. And then put that together into an article that comes down here that's basically cohort studies matched up with another cohort, and then that information comes back up again and becomes part of the large database. So you can see how this is going to change what we consider the top of the hierarchy of data curating and basically of filtered information will be at the top. And so let's look at that and see how does that apply to physicians. And then we're going to come back to our two cases and talk about them. So these are physicians that are being trained decade by decade. This is data as it's growing. And as you can see, it's a huge growth curve, a doubling rate as this data grows exponentially. And so these are medical literature, articles, case studies, presentations, analysis, meta-analysis, randomized studies, all the stuff that's being done, filtering, systemic reviews, and so forth. So in 1960, there wasn't a lot of data, and so basically you had a textbook, and you had some journals coming in, and then you went along and joined on this curve, of information that you pick up through CMEs, through drug reps, through picking up your journal and looking for a synopsis, from basically using online information later. There's no online information now. You had to go to the medical library, and you had to look around and pull articles. And so every hospital had a medical library. And so as time went on, 1970, 1980, people struggling to keep up. They may have a little increment yearly as they keep up in their CMEs, as they learn new stuff, and you see data is continuing to diverge in terms of what you know and what's available. And guidelines basically have become started so that you could have some kind of consensus opinion of what this medical literature could be applied to your patients. And so, but the guidelines would change every 4 or 5 years. And so guidelines were kind of stuck to. So you're coming up this curve, trying to learn as much as you can, and you can see the gaps growing. And if you wanted to, spend an hour a day, which most doctors spend 20 minutes a day, you might be able to get up somewhere in here. If you wanted to spend, 3 hours a week, you might be able to get up some in here. If you had some kind of way of screening data like up to date, and you did that on each one of the patients you saw, you might get somewhere up here. You'd have to have a phenomenal memory to get somewhere in here, and you'd have to be a hermit in a monastery somewhere to get somewhere up in here. And so, but Watson's doing it, and how are we going to bridge this gap? And the guidelines are only temporary for bridging the gap because they're not being changed rapidly enough to bridge this gap. And so it looks like the way we'll bridge this gap is we'll plug in to supercomputers, and we'll have to learn how to ask the right question. And if we ask the right question, like on Jeopardy, then we'll know how to manage a specific patient. And we'll have big data from this information being refined and processed by a supercomputer to feed back to us how we should evaluate a patient. So how can we effectively use Watson or cognitive computing? We need to learn to ask the right question or questions. So let's look at the 2 cases that we've been working on and see what the questions might be. So possible questions about the mid-LAD plaque. Okay, does a high-risk plaque in the mid-LAD, does it need to be stented? And when we know stenting is for symptomatic coronary disease, do we need to do this to relieve symptoms? Well, you saw in these 2 patients, symptoms were very transient, and then after that there were no more symptoms. So is that the way all these cases behave in the mid-LAD, or is that just these 2? Is this a good question? Well, we use a lot of resources when we stent them, and certainly either one of these patients might have been discovered if they'd had a different test. And so cardiac CT may have discovered these lesions, and they could have gone to the cath lab and been stented. So that's entirely possible. Since the same, but we don't know if it's of value. Since the same amount of myocardium is subtended by the mid-LAD lesion compared to an isolated second diagonal lesion, should we conclude that stenting is of low value, as we have done with second diagonals? We usually don't stent them. We just treat them medically. Our studies have shown that there's no difference between stenting or treating medically. Is medical therapy of any help to get rid of symptoms or prevent LV damage from this specific lesion? And both these patients didn't have symptoms after the initial onset, and they didn't have damage because they apparently established collaterals. How do you know if potential collateral vessels are there to save the muscle if there's an occlusion? Is asymptomatic survivorship unique to mid-LAD occlusion? What good does it do to image the plaque to predict occlusion and the benignity of this lesion as opposed to others presenting with the same nonspecific symptoms and more proximal LAD lesions might be the reason to image the plaque? Where is the plaque? Is it proximal LAD prior to the first diagonal, or is it mid-LAD and we don't have to worry about it? Possible questions from the infinite number of questions. From big cardiac data, we can find all the cases. This is a query, okay, after we have the big data that Watson's capable of accumulating from our own cases, okay, we can query this. In big data, we can find all cases of mid-LED occlusions on a CTA, okay, as a N1 that we want to find out. And we can look and see N2, negative troponins, N3, EKG, N4, normal echo. The abrupt onset of symptoms could be number 5 that we're searching for. Symptoms go away, number 6, males, number 7. So we've found here 7 attributes, N1 through 7. But this could be an infinite number of values to search 1 to infinity, but we're capable of doing that within Watson. Predicted outcome. If we have 2 possible values for output, 1-year survivor without symptoms is our output that we're interested in. With medical or interventional treatment, case 1 type. Without medical intervention treatment, case 2 type. That we can actually search and find out, you know, of all these cases that have come into the system, we can figure out, you know, through an algorithm, whether the medical intervention or medical and intervention without can actually result either one in 1-year survival without symptoms. And so that would be the kind of search that we would do. So we have greater opportunity to do that today as we project using cognitive computing in our everyday life, which is going to be occurring sooner than we think. So thank you very much. It's nice having you here. I hope you had a good day. Thanks for attending. Bye-bye.